Okay, I will try to do my best to combine this. There's a lot of questions that arrive. I will see. There's one thing that is repeated in a lot of questions is that we all agree. We discussed during the day that we make a lot of errors in research, and you say, well, what methodologies do we have there to prevent errors? How many type of errors? And there was a question also. Well, let's start with this. Do you have the microphone here for the group? Oh, okay. How can we prevent errors in research? There's a long list of questions. Seems to be that one thing that everybody learns that we are going to make errors. How do we prevent errors, or is there any consideration?
I think there are several stages of research that are particularly error prone. Of course, process. Anything that involves people to do a work is going to have opportunity for error. So I think one way is, are we actually performing the study in an appropriate way? And then we do that by evaluating our process continuously. So, real-time monitoring of how well we are doing, and then even measuring across the researchers performing. Do some have a higher quote rate of consent, successful consenting? That may not be because they're doing a really stellar job. It may be that they're running through and spending very little time in reviewing the consent form. So you really have to have a process to really understand. And I think constantly having researchers describe the process, but the big thing is knowing what the job is and then training for the job. So that's process, making sure the data are there. And then you have to have the analytical assessment of, once you have the data in, does that make sense? And I know Thomas does a lot of data quality.
Yeah, so I think a lot of it comes down to just constantly analyzing the study while you're performing it as well. Because that way you can identify outliers or anything that just looks out of the ordinary. In terms of data collection, you can construct your database in a way that does quality checks for you. So if you enter a value that doesn't make sense, you can kind of flag that value, and then the person entering it can go, make that change if they need to. But I think it's just a constant evaluation of the process is the best way to address and reduce the error.
Yes, I agree. Of course, we are in the same team, but essentially, I remember when we used to do studies a long time ago that you do the study and then you do the data quality at the end, and then you go start getting the queries, and then you have 6 months of data collection, and then you figure out that there was a problem in something, and then you go back to 300 patients to review. This will be catastrophic. Then we, at this moment, what we are doing, something that, again, everything is time and effort, but we're doing data quality essentially real time. Now, to do data quality real time, you need to have a good statistical group that essentially what we did in the last study is that every week we review what happened with the data. Then every week, there was a gap, there was a problem. But to do this, to do data quality real time, but this is critical. To the point that sometimes when I discuss with residents, say, well, this is a group of 3 people who want to review the case reports, or we want to review the medical records of these, 100 patients. I want to do this quality study. And I may say, well, you have 3 people doing data collection. What you're supposed to do is 2 are doing data collection and 1 is doing data quality. Because you need to, and then next month, the other 2 do data collection, 1 is doing data quality. Because you always need to be thinking that you need a team doing data quality. You have only 3 people doing the study where 1 needs to be doing data quality to capture this, to capture the errors that are going to happen. Any other general comments for errors? Yes.
One thing that we didn't really talk about, but we spend a lot of time in our group, and that is feedback. And it's really hard if you're doing data quality. The individual or individuals that have made an error need to know that. And sometimes that's really hard in letting somebody know. And because, the person may feel like, well, I'm being picked on, or, are you singling me out, or whatever. And that's not it at all. The idea is, if I never tell you how well you're doing, how will you ever know, and how will you ever improve? That's why we have evaluations as part of our jobs, right? Why our supervisor lets us know, what do we do well? What do we need to improve? So we need to take that whole notion of feedback with respect to quality very seriously, and do it in a way that, of course, is respectful. But the ultimate goal is, if we don't address quality, we have poor results. So we have to do this. How we do it that's always the nuance, but it is incredibly important.
There are several questions regarding sample size. And one question is, when do you don't need to do sample size in a study? Do I always need to estimate how many patients, or what studies sample? I don't need to call the statisticians to do sample size.
So I guess classical sort of example of this is in animal studies. They'll say we need 3 rats, and so that's an example. No, for a sample size calculation, again, you need to think about your sort of the objectives of your study and your research hypothesis and study question. So if you are doing mostly a descriptive study where we want to describe a population, then you wouldn't need necessarily a sample size calculation for that, because you're not trying to assess any sort of intervention or any sort of groups that the risk factors you identify from that, we still identify them through statistical analysis, but the purpose of that is not necessarily to assess an intervention. So if you ever have like an intervention, or you are thinking maybe there is a risk factor that is really of interest, if your research question is framed in that regard, then it's a good idea to look at sample size calculations. And this is especially important for retrospective studies, because you may find out that if you have at your institution, you want to do a retrospective study on, say, like reducing like antibiotic associated C. difficile. And so when you look at how many cases have we had in the past, and then if we are looking at some intervention potentially that happened as part of a quality improvement project, or that perhaps we're looking at various drugs to see, is C. diff more associated with drugs following this or not. So in this case, if you have a retrospective data collection, you are still limited by the amount of data that your institution has. So doing a sample size calculation for a retrospective study, if you're planning on looking at a risk factor or comparing 2 groups, is still a wise idea, because you might discover that you won't actually have enough samples or enough patients identified through your study to answer that question. And so at that point in time, your only real option is then to plan a prospective study, or to wait a longer time and then come back to that. So for the sample size calculations, if you know a statistician, or have, if your institution or your university has statisticians that you could consult with, you may just run by the idea by them and say, this is a study I'm planning. Do you think I should do a sample size calculation? And going through the study with them, they can also let you know, like, well, based on your research hypothesis, you do or you may not need to look at it. So I would always suggest collaboration whenever possible when planning your study. And yeah.
How much you want to mention anything? Or
Yeah, I mean, I think you kind of nailed it on the head there, but a good example that from our division is the hospitalized incidence of pneumonia study. The objective of that study was to define incidence and epidemiology of pneumonia. So there wasn't really a comparison there. It was just a 2-year period to define the incidence of pneumonia. So you're not really comparing. So a sample size calculation in that scenario isn't really necessary. But now at the end of the study, you can still analyze those secondary endpoints and compare mortality in groups. But we don't really need to do sample size calculations on those secondary endpoints. So it just comes down to the nature of your research.
Then another way to say that we are saying the same, I want to say the same in a different way. Then you sometimes you read in the textbook, if your question is this cause that, if this is be associated with this, if you're looking for a cause effect, usually you're going to need to have, you can calculate the sample size. Is you're going to, as Thomas mentioned, I want to know how common is this in this population. You're not comparing this with that. You want to know how common is this? Then there's no sample size. Then essentially, based on your question, then if you're comparing things, you're going to need sample size. You're not comparing, you don't have the PICO, because the PICO question is, is the population, the intervention, the comparison, the outcome. You are making a comparison. You have you have the intervention, no intervention, the comparison, there is no intervention, then you need a sample size. If you don't know if this is an observation, if you are going to do a question usually on incident, how common is this, or what happened with that, you're not having a comparison, no sample size. There are a couple of questions regarding pediatrics. All my life I've been an adult person, then this is, but regarding pediatrics, one question is what happened with consenting in pediatrics? Do you consent a child, or you consent the parents, or you consent the person that is in charge? And then there's another related question. What happens if the child doesn't want to be on the study and the parents want the child to be on the study, or the reverse? The child, for whatever reason, wants to be, it is a controversy there. I mean, how do you handle these situations? And again, these are all IRB type of, but again, I don't want to have any opinion. I don't have any experience. Anyone with any experience with pediatrics in the audience?
Well, I do not, and you probably just outed me as somebody who's not actually a regulatory expert. However, when you're dealing with vulnerable populations like children, the IRB has very specific guidelines, and it's usually set up by either an institution's policy, like the Children's Hospital might have specific regulations, but there are also federal requirements related to child research, depending on the nature of the research, the age of the child, their ability to understand and assent versus consent. So children can never consent, but they can assent. And whether that is required for the study, that will all be reviewed by the IRB, and somebody there can work with you about that as far as how can you proceed forward, since research in children is a tricky patient population, because you don't want to exclude them, because then you can't actually find out information that would be helpful for children. But this, because oftentimes we say that children are just small adults, but in medicine, that's not actually true. And so doing research in children is very valuable, but there have to be specific protections so that there is understanding, and whether or not the parental consent needs to be there. It's going to be very different depending on if it's an emergency situation or like I said, the nature of the child or the age of the child. So a lot of that I'm not necessarily an expert of, but I will say that there's very specific stipulations in there about that.
Any other general comments? And everything that has to do with legal issues, we have to go and see what the IRB is going to mention. This question read that if you can only choose to control for confounding to either study design or statistical method, which one you prefer? I don't know this. Do we have anyone is better than the other to control for confounding?
Well, I mean, we know randomization is the best way to control for those known and unknown confounders, but we don't, we can't always apply that type of design. You can control for confounding through the methodology and analysis, but if you do one, it doesn't necessarily mean you can't do the other. So you can design a study to control for a certain confounder, and you can control for it later on, a different confounder later on in analysis. I guess personally, I do a lot more of controlling in the analysis phase, just because I work with data and we do that. We run logistic regressions to control for those confounding variables. But I guess to choose one, I don't think you necessarily need to choose. You can be pretty flexible with controlling.
Yeah, then as no, it was mentioned in interventional studies, it was a randomization. Oh, you're going to go ahead.
Well, so just to build upon what Thomas said, a randomized clinical trial is the highest level of evidence from a research like study performing perspective. And you can actually also have sort of almost doubly robust statistical analysis in that if you use, say, stratified block randomization, so you are trying to make sure that every level of a group is evenly distributed between your treatments and your controls, then you could also still include those variables in your analysis afterwards, just to try and make sure that you are still accounting for them. So you can definitely do both. So ideally you would want to try and randomize, but reality is that you can't always do that just because of either monetary concerns or institutional support or the resources you have available.
Yeah, for the randomization, it's going to be a prospective study on consent. You randomize the patient. This implied usually well-funded study. And again, I just want to emphasize, this was already mentioned. There are the confounders that we know. Then we all agree that we are doing a study. Age probably is going to be a confounder. Severity of disease is going to be a confounder. The person is immunocompromised. These are all the things that we know that we can measure, and then we give to the statistician to adjust. The problem are the confounders that we don't know, and the confounders that we cannot measure. As was already mentioned here, patients and everything is very complicated in biology. Even though we say, smoking produces lung cancer, yes, it's clear. But what other confounders are there? We just opened the door of genetics. And we know that genetics probably we learned this with COVID. Why some patients die and the other patient is exactly the same, and the other patient didn't die, and we did exactly the same. There are so many components, and probably the examples of this 1 in 1 million death due to a vaccine is something that most likely in the genetic of this patient that allow this hypercoagulability state that the patient die of severe clots. But we don't have any tests to randomize for genetics. Then I cannot give to Thomas or Stephen the genetic composition of the patient for them to adjust. Then how do you adjust for something that you don't know? Randomization. You are right, flip the coin, you go here. Flip the coin, the other go there. Then the beauty of randomization is that even the things that I don't know that are confounded are going to be more or less the same in the two groups. This is why we go back to the idea that you want to control for confounders, randomization. Because if the confounders were the only ones that we know, they can do multivariate analysis and they can adjust. But the other thing, important thing, let's forget about the ones that we don't know, randomization. But for the ones that we know, the another thing that the statistical team depend on the things that we collected. If we didn't collect the information, they cannot adjust. And I go back to the idea that this is a variable that needs to be in your data collection form and needs to be in your database. Because you didn't collect for this variable, there's no way to adjust. Then we see the circle that going back to the statisticians and the team work. But yes, we adjust for a lot of things for in the analysis phase, that is multivariate analysis. This is the standard. Talking about adjusting for confounders, we didn't have time for the statistician to talk too much, but what about a propensity score? What can you tell us? Because since we're talking about confounder and what is propensity score?
So to try and describe propensity scores, and just very briefly, let's say that you have a small amount of data but you have very many confounders potentially. So you can use a propensity score then, where what you'll do is you'll take your main predictor. So let's say your treatment control, or your at-risk, not at-risk group, and then you'll make that the outcome of a logistic regression, and you'll get the predicted probability that a patient would be in that group based on these other confounding variables. And so what you do then is you would match patients based on those propensity scores to try and match people who are similar. So you would say this person has a high chance of being at risk based on their propensity score. Let's match them, if they are at risk, to a patient who similarly is at high risk but doesn't have this risk factor. And so using that, you can then use matched analyses to incorporate a lot of other confounding variables into sort of one variable. It's called dimension reduction, if we want to be technical with it. But the idea is that you can reduce a bunch of your confounding variables into just a single number to then try to match on. And yeah, so there are some after the fact. Propensity score matching is generally done either after the fact or in more retrospective or observational studies to try and mimic the effect of allocation into groups and matching that way.
And it is you are doing this is a statistical way to almost do the randomization that didn't happen in the retrospective study. There is a question that said, how much or what type of a clinical background should one have in order to be successful in clinical research? What background? I mean, how to be successful in clinical research? With what background?
There you go. Okay, sorry. So I've been fortunate to work with tons of different people in the clinical research realm, and I've seen folks that have a master's degree. I've seen people that are they're a clinician of some sort. They're a nurse. So to me, it's always been whether or not the person is a inherently curious person that is an organized person that's ethical, that really just has virtually every person I know who's been successful in clinical research has a curiosity and always wants to answer a question something more than what's there. So we heard a lot of great examples. That's different than we call them the finishers, those that go and they're publishing a lot. Or you have to have a separate set of dedication. And Jeff alluded to it. When you think about it, 80% of cancer clinical trials never close, never finish to their accrual. Right? So it's actually really hard to do clinical research. The ones that are widely successful are those that are curious and they're finishers. They make sure that they close the loop on what they're doing.
Any other comments for any form of background? Then essentially, curiosity, the idea of trying to help the whole humanity with a particular disease. And then part of another question that is related is how to start in clinical research. What advice do we have if I want to get involved in clinical research?
I'll start just because I've pretty much exclusively done clinical research of the last probably 20 years. To me, it was finding somebody who had a like interest, somebody who shared that interest with me, and we became partners. And you've heard today a bunch about team. It's attaching to a team. And so I tell, and we have a lot of our interns here today, and I'm grateful they came, but ask somebody. I guarantee you, if you went to Dr. Ramirez or any of these folks here and you said, oh, I'm really interested in research, could I come and talk to you and get involved? They would say yes, because you go back to the curiosity piece. These folks and everyone I've known that are really involved in this love to share that wealth with people. So ask for help, take your question and do that. I could give you lists of things that I got involved with that just I went up, one of the biggest things I ever did was I went to Martin Breckbiel at the NIH and asked him, he basically attached proteins to a metal and developed radioimmunotherapeutics. And I just went to him and said, hey, I'm interested in this. I have an idea. And he said, I'll make it for you. I said, could I work in your lab? He said, well, come on over, we'll meet you. And then I had a great career with him, and it was an amazing opportunity. So ask.
And I'll just speak to briefly, you have a lot of people up here who are really, really good at what they do. And if you're sitting in the audience right now, you think, well, I'll never get there. And true, like I will say, I will never be a pneumonologist like Dr. Ramirez, right? I'm not here to try to be an expert in respiratory infections. But if you are interested in getting started in clinical research, find the things that you're curious about. Find that thing, like he said, like that brings out your inner 5-year-old. You know, you see something, you're like, why, right? If you want to know why this is, and then want to explore that more, whatever your discipline may be, or whatever your specialty area might be, you can find information that you will find interesting enough that you can share with others. And so if you want to try to improve something, great, make something better, show that you've improved it, and then share that with others so that they can improve it as well. And that is a great way to get started in research. You don't have to have millions of dollars or have great connections necessarily, but if you want to get started, start with something small and then see where that can go as well. I mean, it's great if you can also participate on a team that's got a lot of big things going, so you can kind of learn through observation or participation. But if there's an area of interest out there for you, you can start asking your own questions. And I think this is really important, especially for the non-physicians out there, because we typically see the things, I gave a whole example of New England Journal of Medicine, right? And even things like JAMA. JAMA is a big article or journal, and it is the journal of the American Medical Association. So they preferentially publish things by doctors. So you don't see a lot of literature that's being published out there that's led by nurses or led by pharmacists out there, because it's traditionally been very much just a medical profession, so to speak. There's a lot of value that could be added by other professions in their disciplines.
I wanted to stand up and scream amen, when you say that. I mean, that is true. And I think, when we look at the future, many of you, the jobs that we will have in the future, we haven't even thought about yet. And so what is the skill set that you're going to take, into the future that's going to make you successful? I would assume that most everybody in the room is interested in healthcare, in the health sciences. We have no idea what the future of healthcare is going to be like. The only thing I can bank on is that it's going to be different than it is today, in many respects. So to be successful in the future, you need to be honest and ethical. You need to be able to work well with others. You need to have that sense of inquiry. I want to know, I want to understand why. You need to be able to take criticism as part of your own approach toward improvement. You need to be able to work well with others and work well as a team. So, it's almost like the life skills that are critically important for research. Now, in infectious diseases, you kind of have to be a person that you're okay if you've got to collect, sputum or a nasal swab or whatever. If you're somebody that says, I can't stand it for somebody to spit, then this may not be the area of clinical research for you, but in another area might. So you may have to be a little bit selective about which lane you're in for research. But to me, it's an exciting field and opportunity, because at the end of the day, I think each one of us wants to feel that our life and what we did has made a difference. And this is clearly a field where you can see, if you do things well, you will make a difference in the outcomes of your friends, your family, parents, your community, just by discovering something new knowledge that then can be applied in the care of others.
Agree. I would add, yes, you want to start, look for a team. Don't try to start alone. Look for a team and look for a mentor inside of the team. Now, the mentor doesn't need to be the person with 100 publications. Your mentor can be the person that is above you, that wants to spend the time to train you and to teach you and to move, and then you move forward and look for another mentor. But it's a team, and look who is going to be as we discussed, everybody in the team is learning, everybody in the team needs a mentor, and everybody in the team is a teacher, is a mentor of the other person. Then this is part of the game. It's part of being part of the research team. This is exactly the question.
I guess that's me. Well, the answer, as with most things, is it depends. I've done them in a couple of days for what is essentially a Survey Monkey online where they have 5 questions. For an extensive NIH proposal, it can take 3 months, 4 months sometimes. So the application burden varies widely. And it's not always the more money you're asking for, the higher the application burden. I mean, I've had grants $300,000 and $400,000 where the application burden was fairly low and the proposal narrative was 3 to 5 pages. So the directions will tell you. Generally speaking, it takes a long time to gather the documents. And that's not something you can fudge. So get started on that early. Check that off the list as you're working on the narrative and the budget. And then do the narrative and the budget. And you may have to call on people across the system for numbers, or a collaborative grant proposal takes longer than something you can put together just on your own. There's very little that you can put together just on your own anymore. So leave as much lead time as you can. That being said, if NIH issues an RFP for a program that you want to apply for and the deadline is 2.5 months, it takes 2.5 months.
About NOFO, what are just some of the acronyms that may be new to?
Yeah, and I tried to say a little bit of that. It's essentially the same thing. I always call it a grant solicitation because that's a broad term, but it's the instructions for what you need to do in order to apply for the money. Generally, it includes with federal solicitations, it includes often a lot of boilerplate from the agency that's just general things about the program that you're applying to. There is often a program officer. There may also be a grant officer or a financial officer that you can contact with questions. If you can, it's a good idea to ask an intelligent question as you're preparing your proposal, just so they kind of know it's coming. A lot of corporate and foundation funders these days have gone to the letter of intent format, where it's a brief proposal. It's not that much less work than a full proposal because you've got to know exactly what you're doing, right? But instead of 10 pages, it might be 3 pages, and you might not have to have a full itemized budget, but you have to know about how much money you're going to request.
Like, what is NOFO stand for?
NOFO is Notice of Funding Opportunity. RFP is Request for Proposals. And RFA is Request for Application. I don't know why everybody seems to want to put their own stamp on the acronym. So that's why I just use grant solicitation when I'm talking about it at seminars.
Yes, and I when I was looking at the question, another way to answer would be, give me the deadline. Because if the deadline is in 1 month, it's going to take 1 month. If the deadline is in 3 months, it's going to take 3 months. Because another thing that happens in writing, probably in general, is that it doesn't matter at what level you are, you get a new version, you're going to have a better proposal. Will be the same that the manuscript. You write this version 15, you move it around, you get better. But then when you submit, the good thing of the proposal, you have a deadline and you have to submit.
So here's a quote. Hemingway once said, "Writing is never finished, only abandoned." So that's your deadline.
Yes. Yeah, yes, that's it. I cannot see this proposal anymore. Let's send it. Yeah, but it's always room for improvement. There's a question here. It seems to be that Furmanek is in love with Red Cap. This is the big. This is your baby. But then, what is the advice for someone that is convinced that red cap is going to be good, but you never done red cap? How to start with red cap? And there is another question that seems to be that they say that then does red cap has any negative points? Because it seems to be that everything in red cap is positive. Does red cap has any negative negative area?
So for the first question, if you are interested in using RedCap, oftentimes if you are a member of a university, the university will usually have a RedCap server or instance that you could use for research there. So I know the University of Louisville has a RedCap that you could use. And if your institution may also have a RedCap instance already implemented. If you don't have either of those options, I would recommend trying to collaborate with someone who does before trying to install your own and set up your own RedCap server, just because there is a lot of technical expertise that's needed there. So you'll need a lot of people who are familiar with informatics in that. So if you don't have the resources to set up your own, I would recommend trying to partner with someone who does and do that. I do love RedCap, but that doesn't mean RedCap it's not always a rosy marriage. So there are a couple of things that I don't think RedCap does super well. And I think those would be drawbacks in most other database softwares as well. So RedCap's reporting capabilities that it has, if you have a longitudinal study or repeated forms, the way to sort those forms in RedCap is a little less than ideal. So I would say that for a standard user, it could be very difficult to try and answer queries and questions that way. So typically when we've had repeated forms and whatnot, it's usually Thomas and I who've been actually the ones trying to do the queries ourselves, because it just becomes, it's a complicated manner. So that would be my only real criticism of RedCap, because otherwise I think it's an excellent tool and for just setting up a study database and housing your data. And Thomas, do you have any additions?
I may say that any person that wants to start learning about databases, you need to use, and you want to do clinical research, you need to use RedCap. We jumped to RedCap years ago when we find out that it was developed, again, with the intention to do clinical research. Now, as was already alluded, it's a community of investigators. And Bill Mattingly, that had COVID, he wrote a textbook on RedCap. Then he's, quote unquote, our expert on RedCap. And he get together with all crazy people doing RedCap investigation, and they do brainstorming, so you have to improve RedCap. Then it's a constant improvement. This is like a Wikipedia of databases. Then it's an international community improving the database. And now plenty of already NIH studies say that for this study, you need to use RedCap. They're already telling you, this is the database that we want. Then, but again, even from the minimal survey to where, then if anyone's going to start learning, you have to learn RedCap because it's here to stay and it's the future. When you have these people doing brainstorming, we can be in our group saying, oh, it would be nice for RedCap to do this. And Bill will be with a group and they are going to bring it. And then people are going to be figure out how to be sure that this new element is going to be incorporated. Then there's going to be no comparison. On top of this is free, then you cannot be better. And now the big companies, you're going to study from, Merck or Pfizer, where they cannot use RedCap because it's not for commerce. But they, as was already alluded, they have to spend the $2 million in these large databases that are very that are different approaches. But for us, RedCap. there are several questions regarding community-based studies. So I say, for instance, how to bring minorities in the US to research. How are sociocultural sensitivities factor into planning community or local research? How do you deal with these sociocultural factors? And again, minorities into research. Any considerations?
I can start briefly by saying that we're currently working on a proposal that has to do with gun violence, and it's important to, in community participatory research, it's important to have the community involved from the beginning, in the planning of the grant proposal and in the planning of the research, so that you don't miss anything. That's a huge question. So,
Yeah, I was with Jeff the other night in a group advisory board looking about vaccine hesitance. And it was eye-opening for me because, we've been involved in the vaccination event from the very beginning, worked with groups and, worked to bring up the Broadbent site and did a lot of work with, other groups, Norton and others that were, at the very, very beginning. And then to hear that there was the thought or from the perception that the methods were not inclusive. That to me said that, our approach in planning was, had some incredible flaws, and that we weren't engaging people from the very beginning. It doesn't matter if the effort is there. If the community doesn't perceive that the effort is there, then the effort isn't there and you're going to be undermined. So, it's a very different way of thinking about, what does it mean to be inclusive? It doesn't mean that one group is right or one group is wrong. It means that when you are at the table, it's a round table and the chairs are full, and that you're constantly asking, do we have everybody at the table we need to have? And you're not just asking those people that will always tell you yes, that you're willing to ask the hard questions and you're willing to take the criticism and realize that, when you are making a mistake. But, this is something that we certainly, we haven't perfected clinical research in any area. We're very far behind because we're dealing with some of the ultimate questions. And that is, can I trust you to bring forward solutions that will not hurt me, that will actually help me? And until we can really get across that very fundamental bridge, then I think that we will continue to struggle. So, now is the time to start that. Really, the time to start it was yesterday, 50 years ago, but, there's no time like the present. So, and again, you are you're the future for us. So it is important that this be, a very a large part of how you are considering a research career and how you are engaging the community from the outset.
It's a huge issue. So my whole career, this has been something that people have spoken about. If you look at research in general, participations, 10% in cancer studies, 10%. So people that know they may have something that will kill them, 10%. If you look at minority involvement, it's less than 5%. And there's a lot of reasons for that. And I think it was alluded to here. The problem is, and something I spoke to in my talk, is that we want simple answers, that there's something that somebody has the magic. I promise you, nobody has the magic answer. It's so complex because if you just living through what we lived through with COVID, right, getting people to be vaccinated, you would have thought that people would just be knocking down the doors, and the percentage of people who opted in was staggeringly low. And even if you look now, how many people have been fully vaccinated? So the issue is we want to have something simple, but it's a very, very complex question more globally. It really goes down to, why do 43% of people get colon cancer screening who are eligible for it? Why is 60% of people who are eligible for mammography getting mammography? So all those things and all those reasons that go into that, magnify that by the underserved populations. And we try to, as a society or as a healthcare academic society, we look at it as a group, but Western Louisville is multiple communities. Go to some of the areas, 42 different languages are spoken in those areas. So it's not a homogeneous thing. It goes back to treating, we try to think in population standards, but really we need to think more individually at times. And how do we construct that? It gets statistically difficult, but that really is the bottom line.
I think that Ruth mentioned in her presentation that the question needs to emerge from the community, and then the investigator needs to be in the community, and then this investigator collaborate with Steve and Thomas to figure out how to do the propensity score, whatever. But the investigator needs to be there. Then another challenge is how to create investigators in the community. Then we are in the process. Man, it's interesting. Norton Healthcare is a big place, but still we're told we need more researchers in Norton Healthcare. There is not enough researchers at Norton Healthcare. There is almost zero researchers in the community. But this is another opportunity for a young person that wants to start. You may want to start in the community and collaborating with the other people. But then you are there, you know the situation, you are talking, the community is going to give you the questions, you know what is the important question and what is going to be the design, and then we have the collaboration. Yeah, this is still a lot that we need to learn. There's another question here, I think that you mentioned this, so, but how you control, this is the question, how you control for bias? I think that you mentioned this. I mean,
so as I kind of made a quick aside earlier, it's depending on the bias, you may or may not be able to control for it. For example, if you have selection bias, controlling for selection bias is difficult because if you would have to redo the study effectively. You know, if we skip all the ICUs, but ICU patients aren't an inclusion or exclusion criteria, we just didn't go to them because it was difficult, then, you know, we're excluding patients who have severe disease, and there we could be excluding from then the results, like important patient population. So there are other ways, you know, I think the minimization, or was it the restriction? Was that the, yeah. So, and you could look at restriction as a tool to try and minimize bias as well by excluding groups that you know, but that also, that speaks more to confounding necessarily than bias. So depending on the type of bias, I think it's very difficult to control for it after the fact. And that's why planning the study and making sure that you've done the study correctly and that you're constantly assessing quality are such important things to do, because without them, then your study might all be, you know, for naught.
Then essentially, again, as part of the, there's another, yes.
I was just going to say one thing real quick. You may not be able to control for bias, but in research, like your own personality, self-awareness is very important. So at least you can be knowledgeable of the bias that is in your study design. If you might be able to change your study design, that would be helpful before you got started. Obviously, having to redo it would not be advantageous, but at least you're aware of the bias in your study so you can speak to it, especially when you're coming up with limitations or when you're discussing your conclusions, so you don't accidentally overstate your findings, because that will definitely get you some comments back on your baby about what you think this study means. So sometimes self-awareness, or just even if you can't control for it, I think the word control probably means, you know, from their perspective, like I have a mathematical plan for it, but at least you can acknowledge it ahead of time and then work with what you have.
Then another way to look at this is, again, bias is, as was already is an error of the study, but there are errors because instead of a sodium 140, I wrote 104, and we can capture this error because nobody can live with sodium 100 And you can, but bias is an error that is part of your study. It's already in your study. and the problem with bias, and I like your concept, for instance, just to extend with what, because this is real life, because we're doing a study now, the study that we're, for some of our group, we're doing a study of for respiratory syncytial virus, that we need to consent the patients because we were so busy, and consenting patients in intensive care unit is more complicated because they're on a ventilator. Then we agree that, well, let's not go to the unit because it's too complicated. We are so busy on the ward, and then we enroll all patients. And then the other day we are analyzing the data, and someone say, oh, what is the mortality of patients with respiratory syncytial virus? And we can say, oh, the mortality is whatever. This is our data. But there's a bias in our study, is that because consenting patient on a ventilator is difficult to find the family, difficult, we decided not to go to the unit. Then, of course, when I look at the mortality of patients admitted to the hospital with respiratory syncytial virus, it's going to be artificially low. This is a bias of the study. I can repeat the study 100 times, and I'm going to get 100 times the same result. And 100 times it's going to be wrong. Then, as Ashley mentioned, it's critical. They say, oh, mortality is only 5%, but you need to write. But one limitation of the study is that we didn't consent patients in intensive care. You see that a bias is something that is part of the study, and there's no way to control it. You control it in your discussion. Say, this is, but then there are other biases that are difficult to control. And I also, I would like to emphasize that we all have bias. There's not a human being without bias. Okay, then whenever you are doing something, you are going to apply your biases to whatever you are doing. And you know, and in this idea of vaccines and all the studies of vaccines, we know even this political bias injected into vaccines. Then even, you know, based on your politics, I can more or less figure out if you're going to get the vaccine or not. I mean, it's crazy, but this is as much of our bias influence what we're doing and influence research. This question said, how is a researcher stay focused on the primary research question? I would say that I like to express it. How is that the researcher stay focused in the study after you go months after months? How do you stay focused on the study and in your primary goal? Any general advice for staying focused?
I think this goes to something I said in my talk. It's amazing how many trials never fully accrue because people get very ADHD, but they go on to the next shiny coin. And that's a huge problem where people lose their sight of what they're trying to go after. So you really have to push yourself to make sure you don't move on. We see it with trials that we open in the clinic. Some people, there's never been a trial they didn't like, so they open every one possible and they're not moving forward. So it takes discipline. It takes a lot of dedication towards that trial to say, you've heard 3 of us talk about how it's your baby, but you got to love all your babies equally. You got to make sure they all grow up. You got to make sure you give that attention. But that's where a lot of them fail, is people lose their excitement onto the next thing. And it's very, very difficult.
Say that, you know, you have to be attentive to your team, and that, you know, your team needs to recognize that you recognize value, and, you know, it makes it meaningful that, you know, I look and I think about, you know, part of our team, Kirsten, has we have the morale committee, or I hope that's the name, happiness committee, or, and you do things as a group. So you see people as people and not as a coworker necessarily, that you bring that personal approach. So I think everybody needs to feel that they're valued. And I think that personal value keeps your group energized. When you fail and when you stop at some point investing in your team, then I think that the team can develop fatigue, just like all of us develop fatigue. And so, you have to be able, whether it means rotating people and, pull back so people get a day out of the same routine so that there can be a refocus and a reinvigorate, and then be able to go back into that. So you need to be listening to your team and asking questions, and then, trying to re-energize regularly.
And I think it just goes back to actually having a vested interest in what you're studying. Dr. Ramirez has a very data-driven mindset. So for me, it makes it very easy to do my job, because I know if I produce something, I'm going to hand it off to Dr. Ramirez, and he's going to feel like he hit the gold mine and struck gold there. So it definitely comes down to having an interest and surrounding yourself with people who are interested in what you're doing and kind of see the potential that you can contribute.
Again, you see that we all agree, and when Ruth gave the presentation, when she discussed finer, the I, he said the research question has to be of interest for the work, but it's critical. It has to be very, very, very interested for you, because it's going to take more energy, more time. It's going to be more difficult. What you think? Then you really have to be interested. Go back to what Joe is saying, that you really need to love your baby, and I'm going to keep going because again, to finish a study is an average if you were to do the full study, from idea to publication, going by doing this, you're going to go to a database, you're going to do the study. It's going to be 2 to 3 years. This is the average. Then, a pregnancy of 3 years, imagine when you have your baby. But this is why I say you need to be really, really interested by whatever idea, because otherwise people just do something, it's getting complicated, I cannot find the place, do another thing, and then you lose interest. There is another question I'm going to throw, is the question of people say that, well, I'm going to need time to write the protocol. I'm going to need time to the study. I'm not going to need time to write the manuscript. Where do you get the time? This is another question. This is another thing that is multiple questions from here, how do you get the time to do this? Because you already convinced me that this is too time consuming.
I hate to be that guy. I mean, I think in the 100 papers I've had, almost all of them were written on nights and weekends, because that's when I have friends who can write, and they can write 4 papers at once. I need dedicated time where I can really think through it, and that's just for me. And then during the day, there's so many other things going on as a clinician, as a administrator, as a researcher, but I think everyone has a little bit of a different plan. Very few people are able to juggle 5 or 6 papers and go from one to the next. I'm one that has to do it, get it done, and move on to the next thing.
Any other comments?
Yeah, I think this is tough, but I think it also goes back to the previous question about how do you stay focused, and it kind of gives you that true litmus test of like, how interested are you in this topic? Coworker of you comes up to you and says, hey, I'm going to do a study on this. Do you want to participate? Do you want to help? You're like, of course, because at the moment, the only commitment that you have to give is your verbal commitment. But the question then really comes down to it. Are you going to spend the time collecting data potentially before work, after work, read the articles that are necessary to get things done in a timely manner? Research is often important, but not urgent. And those are some of the hardest things in life to find time for. And so that does somewhat bring you that litmus test of like, how interested am I in actually doing research? Because everybody likes to talk about protected time to do things. And when you're trying to read and think, having the phones ringing or having to talk to other people coming up and asking questions, it gets very challenging to do that type of work. So how are you going to find the time within your day to get this done? And it's not easy, especially we talk about like, everything's practice. It takes work. Like the first time you do it, it's going to be rough, but then you're going to get better. It's a skill that you have to keep working at. And you will get to the point where potentially you can do multiple manuscripts at the same time, but starting small and building on that process will really help you ease into that instead of trying to be really overwhelmed at once. And we'll say the other thing too, is we talk about collaboration and working with your team. That form of peer pressure can also be very motivating. If you agree to be part of a project and then we're working on a draft of something and you don't have time to review it and everybody else is waiting on you to get that comments back, again, maybe that's time to self-reflect to say, how committed am I to this project? But it also can be a really great motivator to say like, hey, this team has a plan. I'm going to hold myself accountable to meeting this plan and work around that versus trying to find that magical moment when you have quiet time to sit and focus and read.
Yeah. I think a lot of it too is coming to grips with generational approaches. When I was 15, I remember my dad said, Ruth, I need you to do something for me. And I'm like, oh, I just don't have time. And he said, gosh, that's a shame, because after you finish that, I was going to put you in a room and tell you, Ruth, now go pick up all the $20 bills you have time for. $20 was a lot, back then. But the moral of that story is that you have time for the things that you value and you think are important. Well, that's easy to say, right? We have a lot of competing priorities. Now, somebody like me, I tell people I don't actually know how to do anything else. Plants, I don't grow. Cooking, I don't do. I just don't do that. So I've decided that these are the things I want to do, but each person has to develop that individually. If this is a career that you want to go and you want to excel, it's going to take devotion. You're going to have to spend time outside work. You're going to have to, decide what do you want to give and, what do you want to give up. But then that will place you in the future, that your career is an investment and research is an investment into yourself. And then that will help determine where you are in this field as a future career. But it won't just happen without some sacrifice. It just won't.
Any other comments regarding time? This is, again, I completely agree. I would say that going through the three comments, Dr. Flynn mentioned that to write, you need to have quality time, because you never get quality time during working hours. It just doesn't exist. And we know by biology that this idea that young people have that you can multitask, you can think that you can multitask, but the brain cannot multitask. The brain do one thing at a time. And when you do multiple things at a time, you don't do anything right. You can do multiple things, but not, and writing requires concentration. Then usually it's going to be outside of work, and outside of work for us is weekends. When you have 2, 3, 4 hours that you can concentrate and you write and rewrite and rewrite, then you need to find quality time for writing. I also agree with Ashley comment, because she almost is giving you the time management that this is not there. The 4 quadrants: writing, clinical research, writing a protocol is in the quadrant or very important but not urgent. You have important, non-urgent, important, urgent, and then non-important, urgent, and non-important, non-urgent. You have the 4 quadrants, the 2 by 2, and we can do, this is time management, the 2 by 2. On one hand, you put urgency, otherwise you put important. And the problem is that writing is very important, but it's non-urgent. And this is the quadrant that people go from the unimportant, non-urgent. They respond in the email, going to the social media, doing all these things that you spend all the time. And then you spend 1 year, you don't know what you've been doing for the last year. This is all part of the process. Then these have been all very important advices for people that already done it. Okay. And I may say that this is, I love it that there are 20 more questions, and I'm feeling bad that we didn't answer your question, but we need to finish this round table. We want to understand that you then completed clinical research from idea to publication is going to be You need to complete the post-test. You will receive an email with all the information. And I want to thank all of you for your participation, all the people that have been in our virtual communication, and of course, all the speakers today. Thank you very much. Thank you to everybody. Thank you. Thank you. And the last favor that I would like to ask is that we would like to see if you can move to the front, because we would like to make a picture of whatever survivors we have still. It's almost 4:30, 5 o'clock. I would like to get, if you want to be part of the picture, we have to have a picture of all of us. Meanwhile, said when to get the white camera for the, and then the idea will be we can have someone, we're going to have chairs here. We want people in the chairs and people in the back, and we try to get a picture of as many of us as possible. Okay, very good.